Welcome to today's lecture on endocrinology, where we will delve into the intricate topic of the parathyroid glands and their role in maintaining calcium balance. These small glands, located behind the thyroid gland, secrete parathyroid hormone, PTH, which is vital for regulating calcium levels in our bodies. Throughout this lecture, we will explore the anatomy and physiology of the parathyroid glands, the synthesis and secretion of PTH, how PTH interacts with vitamin D, and the factors influencing PTH secretion. Additionally, we will discuss the diagnostic approach and clinical significance of abnormal calcium and PTH levels. Get ready for a comprehensive journey into the fascinating world of parathyroid endocrinology. The parathyroid glands are small glands located on the back of the thyroid gland. They play a critical role in maintaining the balance of calcium in our bodies. The main cell type in the parathyroid gland is the chief cell, which produces and releases parathyroid hormone, PTH. Another type of cell, called occipital cells, has a less understood function in calcium regulation. The parathyroid glands have a rich blood supply and are also innervated by sympathetic nerves, which may impact PTH release. The overall function of the parathyroid glands is tightly regulated to maintain normal blood calcium levels. Parathyroid hormone, PTH, is a small protein hormone consisting of 84 amino acids. Its synthesis begins in the chief cells of the parathyroid glands, where pre-pro-PTH is first produced. Pre-pro-PTH undergoes a series of enzymatic cleavages within the endoplasmic reticulum and Golgi apparatus, resulting in the formation of pro-PTH. Pro-PTH is then further processed within the secretory vesicles to yield the biologically active PTH hormone. The secretion of PTH is tightly regulated and mainly influenced by the serum calcium levels. When calcium levels in the blood decrease, the parathyroid glands sense this change through calcium sensing receptors and respond by increasing PTH secretion. Conversely, when calcium levels rise, PTH secretion is suppressed. Additionally, other factors such as phosphate, magnesium, and vitamin D levels can also modulate PTH synthesis and secretion. The intricate interplay between these factors ensures tight control over calcium homeostasis in the body. The release of parathyroid hormone, PTH, is regulated by multiple factors. The main regulator is the level of ionized calcium in the blood. Calcium sensing receptors on parathyroid cells monitor calcium levels. When levels drop, PTH secretion increases. Other factors, such as phosphate, vitamin D, and magnesium, also affect PTH release. Low phosphate levels stimulate PTH secretion, while high levels inhibit it. Vitamin D works with PTH to promote its secretion. Magnesium has a complex role, with both low and high levels suppressing PTH secretion. This finely tuned regulation ensures the optimal maintenance of calcium levels in our bodies. Once released into the bloodstream, PTH exerts its effects on target organs, primarily the bones, kidneys, and intestines, to maintain calcium balance. The main target of PTH is bone, where it stimulates the activity of osteoclasts, cells responsible for bone resorption. By activating the osteoclasts, PTH releases calcium from bones into the bloodstream, thereby increasing serum calcium levels. In the kidneys, PTH acts by reducing calcium reabsorption in the renal tubules, leading to increased urinary excretion of calcium. This action helps to eliminate excess calcium from the body when levels are elevated. PTH also acts on the kidneys to increase the production of an enzyme called 1-alpha hydroxylase, which converts inactive vitamin D into its active form. Active vitamin D further promotes calcium absorption in the intestines, thereby increasing calcium levels. Overall, the actions of PTH on the bones, kidneys, and intestines work harmoniously to maintain optimal calcium levels in the body. Upon binding to its receptor, PTH initiates a cascade of cellular signaling events that culminate in the desired physiological responses. The PTH receptor, also known as the PTHR1, belongs to the family of G protein-coupled receptors, GPCRs. Activation of the PTH receptor leads to the activation of numerous intracellular signaling pathways, including the cyclic adenosine monophosphate, CAMP, pathway and the phospholipase C, PLC, pathway. Through the CAMP pathway, PTH stimulates the production of cyclic AMP, which in turn activates protein kinase A, pKa. pKa then phosphorylates various intracellular substrates, leading to downstream effects such as increased osteoclast activity and enhanced calcium reabsorption in the kidneys. The PLC pathway, on the other hand, leads to the activation of protein kinase C, PKC, and the release of intracellular calcium stores. These signaling events contribute to the overall response of target organs to PTH and help maintain calcium homeostasis. PTH and vitamin D interact closely to regulate calcium balance in the body. PTH, as mentioned earlier, stimulates the production of active vitamin D in the kidneys through the activation of 1-alpha hydroxylase. Active vitamin D, also known as calcitriol, increases calcium absorption in the intestines, allowing the body to replenish its calcium stores. Active vitamin D also exerts a negative feedback influence on PTH secretion. When calcium levels are sufficient, calcitriol inhibits PTH synthesis and release, thus preventing excessive calcium mobilization from the bones and suppressing PTH-induced calcium reabsorption in the kidneys. This delicate interplay between PTH and vitamin D ensures precise regulation of calcium levels and maintains the integrity of skeletal and extracellular calcium levels. The secretion of parathyroid hormone, PTH, is influenced by a variety of factors beyond calcium levels. Some of these factors include serum phosphate levels, magnesium levels, and vitamin D status. Low serum phosphate levels, also known as hypophosphatemia, stimulate PTH secretion. This physiological response helps to restore phosphate levels and maintain a proper balance with calcium. Conversely, elevated phosphate levels inhibit PTH secretion, preventing excessive phosphate retention in the body. Magnesium, like calcium and phosphate, also plays a part in PTH secretion. Low magnesium levels, known as hypomagnesemia, stimulate PTH release. On the other hand, high magnesium levels, or hypermagnesemia, suppress PTH secretion. Vitamin D, as mentioned before, also influences PTH release. Active vitamin D, synthesized in the kidneys under the influence of PTH, suppresses PTH synthesis and release when calcium levels are sufficient. These factors collectively modulate PTH secretion and contribute to maintaining calcium and phosphate homeostasis. Calcium sensing receptors, CASRs, are critical regulators of parathyroid function. These receptors are predominantly expressed on the surface of parathyroid cells and continuously monitor extracellular calcium levels. When calcium levels decrease, CASRs detect this change and initiate signaling pathways that stimulate PTH release. Conversely, when calcium levels rise, CASRs sense the change and signal the parathyroid cells to decrease PTH synthesis and secretion. CASRs interact with a variety of intracellular signaling molecules to exert their effects. Activation of CASRs leads to the inhibition of adenyl cyclase, reducing cyclic AMP production and subsequently suppressing PTH secretion. The role of calcium sensing receptors in PTH secretion highlights their importance in maintaining calcium balance in the body. Disorders associated with parathyroid dysfunction can manifest as either hyperfunction or hypofunction of the parathyroid glands. The most common disorder is primary hyperparathyroidism, characterized by excessive PTH production and secretion. Primary hyperparathyroidism can be caused by a parathyroid adenoma, which is a benign tumor within the parathyroid gland, or by hyperplasia of the glands. In both cases, excessive PTH release leads to abnormally high calcium levels in the blood, which can result in symptoms such as fatigue, bone pain, kidney stones, and gastrointestinal disturbances. On the other end of the spectrum is hypoparathyroidism, characterized by inadequate PTH production. Hypoparathyroidism can be congenital or acquired, with the latter often resulting from surgical removal of the parathyroid glands during thyroidectomy. Inadequate PTH levels lead to low calcium levels, causing symptoms such as muscle cramps, numbness, and tingling. These disorders emphasize the delicate balance maintained by the parathyroid glands and the consequences of its dysregulation. When a patient has abnormal calcium levels, a systematic approach is used to diagnose the problem. This involves measuring levels of serum calcium, albumin, and parathyroid hormone, PTH. Additional tests, such as measuring ionized calcium, phosphate, magnesium, and vitamin D levels, may also be necessary. The first step is to measure total calcium levels, but it's important to consider the effect of albumin levels on total calcium. Albumin binds calcium, so corrected calcium levels can be calculated to give a more accurate representation. Measuring PTH levels at the same time helps determine the cause of the abnormal calcium levels. Elevated PTH suggests primary hyperparathyroidism, while low PTH indicates hypoparathyroidism or other causes of low calcium. A comprehensive evaluation of multiple factors is vital for diagnosing calcium disorders and making appropriate treatment decisions. Interpretation of calcium and parathyroid hormone, PTH, laboratory test results requires a comprehensive understanding of reference ranges and their clinical implications. Normal total calcium levels generally range from 8.5 to 10.5 mg/dl, 2.2 to 2.6 mmol/L. However, it is important to bear in mind that reference ranges may vary among laboratories, and clinical judgment should be exercised when interpreting results. Ionized calcium measurements provide a more accurate assessment of calcium status and are especially useful in patients with abnormal albumin levels. PTH levels are typically assessed alongside calcium measurements to aid in the diagnosis of calcium disorders. Elevated PTH levels indicate primary hyperparathyroidism, while low or undetectable levels suggest hypoparathyroidism or other causes of hypocalcemia. Comprehensive interpretation of calcium and PTH laboratory test results, with consideration of clinical context, is crucial for accurate diagnosis and subsequent treatment decisions. Abnormal calcium and parathyroid hormone, PTH, levels can have profound clinical implications. Excessive PTH secretion, as seen in primary hyperparathyroidism, leads to hypercalcemia, which can result in symptoms such as weakness, fatigue, kidney stones, and osteoporosis. Prompt diagnosis and appropriate management are crucial to prevent complications and maintain normal calcium homeostasis. On the other hand, insufficient PTH production, observed in hypoparathyroidism, causes hypocalcemia. Hypocalcemia manifests as muscle cramps, numbness, tingling, seizures, and even life-threatening arrhythmias. Correction of calcium levels and careful monitoring are essential in managing these patients. Abnormal calcium and PTH levels also serve as markers for various underlying conditions, including chronic kidney disease, vitamin D deficiency, and certain malignancies. Investigating the underlying cause and implementing targeted therapy are key in optimizing patient outcomes. In conclusion, the parathyroid glands and parathyroid hormone, PTH, have a critical role in regulating calcium levels in the body. Factors like calcium, phosphate, magnesium, and vitamin D work together to maintain optimal levels of calcium in the blood. Understanding the anatomy, physiology, synthesis, and secretion of PTH, as well as how it interacts with other hormones like vitamin D, gives us insights into the complex nature of calcium balance. Disorders like primary hyperparathyroidism and hypoparathyroidism highlight the importance of accurately diagnosing and managing abnormal calcium and PTH levels. As future healthcare professionals, it's important for us to understand parathyroid endocrinology to provide the best care for patients with calcium-related disorders. By integrating this knowledge into clinical practice, we can make a significant positive impact on patient outcomes and well-being.